This diet was standard of care for obesity, type 2 diabetes, and type 1 diabetes all the way back to the 1700s. What this diet does is it reduces the overall glucose load. So at the first meal, you start to see this dramatic reduction in insulin. Your body starts to shift its primary fuel substrate away from glucose towards fat, the ketogenic diet.
Dr. Andrew Koutnik,
a metabolic scientist
who has just completed the longest study ever published on a high-fat, low-carb diet.
with some surprising results.
One of the common effects of a ketogenic diet is the elevation in LDL cholesterol. Over a 10-year period in a high-risk population, the ketogenic diet led to normalization of glycemic control, an over 40% reduction in insulin. But in association with that, no signs of cardiovascular function and physiology was often superior to individuals without any disease.
What do you think are the top 5 foods that somebody needs to eat to do a well-rounded ketogenic diet?
I would primarily think about something like...
As soon as you start a high-fat diet, especially one high in saturated fat, most likely your LDL cholesterol will go up. And when this happens, your doctor will say, stop. And why? Because they'll say there is no long-term evidence to show that what you're doing is safe. Until now. My guest today is Dr. Andrew Koutnik. He's a metabolic scientist, a type 1 diabetic, and has just completed the longest study ever published on a high-fat, low-carb diet and cardiovascular risk. And the results are surprising. Today we're talking about saturated fat, what happens to LDL cholesterol, ApoB and calcium scores, and what truly matters when it comes to cardiovascular risk. So Dr. Koutnik, my first question, let's start off with the big picture. Most people know somebody that has type 1 or type 2 diabetes, either fatty liver disease or a condition of insulin resistance. As a metabolic scientist, what do you think is the biggest factor contributing to all these diseases?
That's a very, very complex question. And I think it often gets watered down, but to really try to explain it best to your audience in reality of what we understand currently based on the evidence and the science is that there's a very complex disease states, obesity, type 2 diabetes, and I would argue they're along the metabolic spectrum, where you have healthy, obese, then ultimately pre-diabetes, and ultimately something like type 2 diabetes. And it really is an interaction between genetics and environment, where the environment interacts with genetics to ultimately express your genes in a particular way. So let's say that you're born with this inherent framework, but then you're able to alter that framework or change the way that framework works by altering things like lifestyle, what you're exposed to in the environment, and other factors. And arguably, when you ask, what's the primary risk factor, one would contend altered metabolism. So altered metabolism, dysfunctional metabolism is one of the key underlying root causes of these conditions. So what does that mean? Well, let's first take obesity. A lot of people recognize obesity as this condition of superficial appearance. So this excess buildup of what we, as a body mass, but what we really care about is the fat mass. And we've often described this in very simplistic terms. Okay, excess intake, reduce energy expenditure, the balance of how much you eat versus how much you burn leads to an abundance of fat if you eat too much. It's been simplified down to that level. But under the hood of someone who's developing obesity, eventually potentially getting to prediabetes and ultimately type 2 diabetes, it's much more complicated than that. So someone who has obesity, they have generally around 2 to 4 times the amount of fat. So about 2 times the amount of total body fat and 4 times the amount of fat in the abdominal region compared to those who don't have obesity. But what we start to see is these signals in the body of the things that's changing in our metabolism that are causing adverse effects. One your audience is probably very familiar with is insulin. We know that in people with obesity, that they can present with up to 2 times the amount of insulin. I would actually not say up to, but they start to present with double the amount of insulin, not just fasting, but also in response to, let's say, a glucose challenge. So you eat some type of carbohydrates, your glucose elevates, you'll see twice the amount of insulin in people on average who have obesity. But this is coupled or often associated with reductions in what we call insulin sensitivity. So things like your whole body's insulin sensitivity, or even tissue specific changes in insulin sensitivity, like in the liver, where that's where you store glucose molecules, and insulin is what binds to the liver and keeps it as glycogen. But we see, reductions in 36% of liver insulin sensitivity, reductions in muscle insulin sensitivity of around 35%, using really gold standard techniques of actually doing things like infusing glucose and insulin simultaneously to actually capture how glucose is moving into these tissues and how much insulin is needed to do that. But we also see some early signs in obesity of disruption to other hormones outside of insulin, like leptin, which can increase up to 7-fold in obesity. So when we're really thinking about, obesity, we think about the superficial whole body weight changes and fat tissue changes, but it's often associated with this change in insulin. But insulin sensitivity is reducing, often around 33%. But we know that it's much more complicated than that, because we actually see in things like obesity of increase in production in liver fat, which your audience will think, well, why do I care if fat's in my liver? Well, your audience may have heard of something called fatty liver disease, which is now called metabolically associated steatotic liver disease, or MASLD. And it's irrelevant. It just means that there's this increase in fat in the liver, which can cause widespread metabolic dysfunction and disease. Well, we see that even in obese individuals, that the production in liver fat goes up 65%. Oxidative stress goes up 32%. But keep in mind that all of this is occurring before we actually see changes in glucose or even liver fat. So the production and the amount of fat from the liver is going up, but the amount and the amount of insulin we need on a regular basis to maintain glucose is going up, but the actual glucose level is not changing. This is why we talk about a metabolic spectrum, because as you go from healthy to obese, you start to see these changes. And obviously the amount of adipose tissue, the amount of insulin required to metabolize nutrients. But we don't actually see the end signal of elevation in glucose or disease elevations in fat in the liver. But if you actually look at obese individuals as they progress, before they get type 2 diabetes, there's this progressive metabolic dysfunction. So you can take an individual who has the same body weight and same overall fat percentage, and match them for age, match them for sex, match them for muscle mass. And as they progress in metabolic dysfunction, you actually start to see a distribution in where the fat is actually being placed. So you actually see reductions in things like placement in fat in the periphery, like in the thigh, but a dramatic increase, 73% in visceral fat, which is the fat in the intra-abdominal, so the stomach region, which ends up being around 3.3 times that of the general population who don't have obesity. We also know that liver fat, which we scientifically term intrahepatic triglycerides, which is the measurement of the amount of fat in the form of triglycerides in the liver, which we do with an MRI scan. We see that individuals who got this progressive form of metabolic dysfunction with obesity have 6.4 times the amount of liver fat. And virtually all of them begin to get diagnosed with MASLD. So the actual diagnosis of fatty liver, or what's now called MASLD, requires over 5% of the liver to be saturated with fat. But we know that individuals who start to progress down the metabolic dysfunction train with obesity can present on average around 15.9% liver fat. And ultimately, we know things like insulin resistance become even more progressive. So, 4 to 5 times more insulin, 70% reductions in insulin sensitivity across virtually all tissues, the liver, the muscle. We also know that the incidence of things like prediabetes begin to emerge, where you actually see now at this stage, a more progressive forms of metabolic dysfunction in obesity, 20% higher fasting insulin, 15% higher of this measure called hemoglobin A1C. It's a 2 to 3 month average of the amount of glucose that binds to tissues. And we see that also goes up alongside fasting glucose levels, along with other disruptions that we don't see in early forms of obesity, like amino acid metabolism, lipid metabolism, further elevations in inflammatory markers, oxidative stress. These all begin to go up, including a 500% increase in markers of blood clotting and inflammation. So we know that as you go from healthy to obese, there's changes that are being observed under the hood that most people don't realize until they start seeing signals like blood glucose changes as they become more metabolically unhealthy. And at this stage, we know that there's actual clear signs of cardiovascular dysfunction already. Increases in things like the stiffness in the vascular wall. The amount of stiffness reduces the compliance of the blood vessels. So you start to see endothelial dysfunction and ultimately changes in the structure of the heart. So an increase in 25% in heart mass. So in summary, when people go from healthy to early obesity to more progressive obesity, essentially they're progressing in the insulin resistance. They're changing the way the fat's being distributed in the body. They're getting diagnosed on average with fatty liver, what we now call MASLD. We see widespread metabolic dysfunction in things like amino acids, lipids, inflammation, and oxidative stress that's progressive, and ultimately clear signals of changes in cardiovascular dysfunction. And when you get all the way to the tipping point at the very end, you get something called type 2 diabetes, which is the progression, the ultimate progression in this path, which really is the diagnosis of full-fledged insulin resistance. Patients often live with blood sugars around 160 to 180 milligrams per deciliter. For those who are in millimoles, that's somewhere around, let's say, 8.5 to 10 millimoles, 500 to 100% elevations in inflammatory and oxidative stress markers, ultimately resulting in 2 to 4 times the risk of cardiovascular disease and an expected reduction in life expectancy. So how long you'll live by an average of anywhere between 6 to 14 years. So we know when we think about the risk factors or the causes of, let's say, obesity and type 2 diabetes, it really is a metabolic spectrum that's very complex, interactive, that progresses over time with a host of different complex changes. So it's not one single factor, but often we can look at key signals, the most prominent ones being insulin and also glucose as measures of where we are in that disease process.
Absolutely. Now, as you mentioned that with these chronic diseases, it could be things like obesity, type 2 diabetes, or even fatty liver disease. It is a multifactorial condition, meaning there's a variety of factors that are affecting the metabolic changes. But as you mentioned, there are 2 things that we need to focus on: elevated insulin and elevated glucose. However, when most people go see their doctor, they're going to say cholesterol. You need to lower your cholesterol, especially your LDL cholesterol. So a question for you as a metabolic scientist: what is more important, lowering the LDL cholesterol or fixing the insulin and the glucose?
This is unpacking a very important question because a lot of people focus on LDL because there's been all these studies in cell culture models, animal models, and these associative studies at general population level that show that progressive elevations in LDL lead to increased risk for atherosclerosis, or the laying of new plaque within the vascular wall. And ultimately, that leads to cardiovascular disease. We know that LDL is a required part of putting plaque in the vascular wall. Another reason why many people believe that LDL is causal in cardiovascular disease. And yes, there is plenty of data in the general population that elevations in LDL are associated with elevations in cardiovascular disease. But in diseases like diabetes, both type 2 diabetes, and we can talk more about this, but also type 1 diabetes, which is a very unique experimental setup where you can really tease apart causes and effects of things like glucose and insulin. We see that LDL is not even close to the top risk factor for cardiovascular disease. We see that glucose and insulin are not insulin, but glucose is the primary risk factor for cardiovascular disease. Not even close, far and away the top risk factor in that disease state. In fact, studies in diseases like type 1 diabetes, where they've actually given more insulin to get only marginal improvements in glycemic control, lead to dramatic reductions in not only the incidence of diseases of the heart and the vasculature, but also diseases of the eye, like retinopathy, diseases of the kidney, like nephropathy, and also nerve damage. So despite patients taking more insulin, despite patients becoming obese, and in fact, the study was over 1,000 patients over 30 years in a randomized controlled trial setup, they found that patients went from 0% obesity rates to 30% obesity rates. And despite all of that, the risk for cardiovascular disease through about a 1% absolute unit improvement in HbA1c, a metric of better glucose control, resulted in dramatic reductions in cardiovascular disease which is called macrovascular disease, and things like eye damage, kidney damage, and nerve damage. So this brings back the key point that glucose, particularly in these settings, as you become more progressive in the metabolic dysfunction from healthy, obese to ultimately type 2 diabetes, glucose is far and away the leading risk factor, not just in type 1, but also multiple studies have shown this in type 2 diabetes.
It is important to understand that LDL cholesterol does not drive cardiovascular risk. And by that, I mean heart attacks and strokes. It's a very low risk factor. And insulin and blood glucose is one of the top risk factors when it comes to cardiovascular risk. I do want to understand more deeply glucose because we hear different things. HbA1c, fasting glucose, and glucose. Can you explain the difference between HbA1c and blood glucose?
So blood glucose level is the amount of blood or glucose circulating in the blood. So you have, as people throw the estimate around of 5 liters of blood in the average person. Obviously, someone who's taller and larger would have more blood flow in their body versus someone who's shorter would have less. And ultimately, it's hard to go and take a singular snapshot of what's happening over multiple months of lifestyle effects, environmental effects, genetic interaction between those factors, and ultimately understand what is the risk. If you just go in and get a blood sample, in a lab, and it says, hey, your glucose at this single time point is elevated. Well, what does that even mean? A single time point is a single second of a single day of blood work you may get every 6 to 12 months. It's not telling you very much at all about your total control. And when we talk about chronic disease and the impact of chronic disease, what we're really talking about is the accumulation of the impact of these metabolic changes over not just a short term, let's say a few months, but over the lifespan. And so what HbA1c is, it was a measure discovered back in the 1960s and 1970s from actually an Iranian scientist who looked at his population and found that when he actually looked at hemoglobin molecules, so pulling blood, look at hemoglobin, he found that there was levels of glucose being elevated or being attached to these blood molecules, these circulating blood cells, in what they call the A1 subunit. So you have these blood cells, and on the blood cells, there's a structure of it called A1C, and glucose would actually bind to that subunit. And he was able to quantify that and see that patients who had diabetes had much higher levels of this. And over time, we found that this is actually a representation of around the average glucose control over a 2 to 3 month period. So when you go to the doctor's office, you get your blood drawn, they're able to look with a single snapshot, what is the average glucose control you've had over the last 2 to 3 months? And so it's a better measure of chronic risk. In fact, HbA1c is the leading risk factor for cardiovascular disease and diseases like type 1 diabetes. And I would argue and contend that multiple studies have shown the same thing in type 2 diabetes. It's a more chronic measure, and chronic is what we're really concerned about, not a single snapshot. Analogous to cigarette smoking. You don't hear of anyone who went outside and smoked one cigarette getting lung cancer, but someone who's smoked cigarettes multiple times a day, increasing their use over multiple years, those are the people at dramatically increased risk for lung cancer, not someone who did it one time.
So HbA1c is a measure of your long-term risk factor, your risk factors for getting disease. It's not just a single moment like blood glucose. So then, to understand cardiovascular disease, like heart attacks and strokes, because I think people want to understand, what do I need to look at to understand my risk factor for that? And many doctors are going to consider LDL cholesterol as the main risk factor for cardiovascular risk. Do you think that's true?
It is very context dependent. So when we look at things like type 1 and type 2 diabetes, what we're often looking at is the risk factors. What is the risk factor that leads to this end stage disease? And so that's these biomarkers we're talking about, like HbA1c, that allow us to get an association between, okay, if we know we have elevations in glucose levels that are high and more variable over time, we know that this will lead to higher risk for cardiovascular disease. So it's looking at these intermediary biomarkers that give us a signal for what the risk is for ultimate end-stage cardiovascular disease. However, it's also important to appreciate that you can actually see signals of cardiovascular disease changes much earlier on, which we can talk about more a little bit later, but you actually see that the vascular function begins to change, how the blood moves through the body changes, and also how the heart functions begins to change before you actually can detect any plaque within the vascular wall. And that's something that is often not appreciated because most people just look at end-stage signals to say, hey, do you have dramatically increased cardiovascular disease risk? But we see that the intermediary biomarkers, things like glucose control, insulin is a risk factor. As these are higher and higher levels, there's a dose-dependent response between those in cardiovascular disease, which again associates back to a key question you asked, which is what's the leading risk factor? And we know that there have been studies looking at over 1,000 patients over 30 years with diseases like diabetes, and we see that the leading risk factor in this disease, again, is glycemic control through a measure of HbA1c, this 2 to 3 month average of glucose control. But of all the top modifiable risk factors, the next modifiable risk factor is blood pressure. So how much pressure is against the vascular wall, your blood vessel walls at any particular time? Because as more pressure accumulates, the vascular wall starts to change in ways you don't want. So more stiff vascular walls. But also triglycerides, resting heart rate. All of these are risk factors that are much higher in the hierarchy of what leads to cardiovascular disease compared to LDL, which is actually the lowest of let's say, the 10 both modifiable and non-modifiable risk factors that are often looked at in the context of diabetes. So to your particular question, we look at the intermediary biomarkers because they predict future risk, but we have to focus on the biomarkers that matter most in a hierarchical fashion, right? So if you were to do an intervention that dramatically improved LDL but worsened your HbA1c, that's not a good trade-off. But if you can improve something that improves your glycemic control, but it may alter LDL, glycemic control is the primary risk factor. So that may be an ideal trade-off. Ideally, you want to improve both, but you have to focus on hierarchy. You have to focus on what we know matters to long-term risk, and ultimately, what is the end stage of that, which is cardiovascular disease.
Let's talk about the biomarkers that you say matters, which is HbA1c, fasting glucose or glucose, and insulin. What is the number one dietary intervention that someone can do to fix those biomarkers?
Yeah, so one thing that we've been very interested in is these diets that reduce glucose load in the body. Because when you think about diabetes, both type 1, type 2, and diabetes in pregnancy, called gestational diabetes, the diagnosis for this isn't elevated insulin. It isn't elevated LDL or amino acid changes in metabolism. It's not any of these factors. It's actually the elevation in glucose. So when you think about what intervention could we consider that could dramatically improve outcomes, it's very logical to consider an intervention or a diet that reduces the amount of glucose in the diet. And obviously, how would you do that? Well, the most potent macronutrient, so macronutrients are protein, fat, carbohydrates. Carbohydrates far and away are the most potent factor increasing glucose levels in the blood, and they do so in a dose-dependent manner. Protein does increase glucose, but it only does so at 2.3 times less per gram. So let's say you consume 50 grams of glucose from potatoes and 50 grams of glucose from chicken breasts, 50 grams of protein from chicken breasts. The amount of insulin with or the amount of glucose from carbohydrates and associated insulin levels are going to be 2.5 times higher. But what about fat? Fat has virtually no meaningful effect on insulin level. And so there is this diet that many people have heard of called the ketogenic diet. And this diet is a diet that is much lower in the amount of carbohydrates in the diet. It prioritizes protein and fat and reduces the amount of carbohydrates. Now, it's not zero carbohydrates unless you go to the far end of the spectrum, like let's say carnivore diets, or there's something called a lion diet. But with a ketogenic diet, it still has some forms of carbohydrates, typically less than 30 grams per day, but in the form of like spinach, broccoli, cauliflower, very fibrous forms of carbohydrates, which most people would think, okay, I know spinach, I know cauliflower, I know broccoli, those are healthy carbohydrates. And so it has those type of carbohydrates to maintain fiber and phytonutrients, but it has well-formulated levels of protein to maintain muscle mass. And then the rest of the calories are made up from healthy forms of fat that come along with a diet. So it's this diet dramatically reducing the amount of carbohydrates in the diet. Now, it's important for people to appreciate that this diet, which we now term therapeutic carbohydrate reduction because of its powerful therapeutic effects, has been around for well over 200 years. In fact, this diet was standard of care for obesity, type 2 diabetes, and type 1 diabetes all the way back to the 1700s. In fact, many people may be familiar with this world famous diabetes center called the Joslin Diabetes Center associated with Harvard Medical School. Well, Joslin himself, as well as another physician called Dr. Allen, were actually doing these forms of diets in patients with type 1 diabetes to extend the life of patients before they discovered insulin. So it's been around for hundreds of years. It's been around for over 100 years for neurological disorders like epilepsy. But what this diet does is it reduces the amount of carbohydrates in the diet, which immediately, within less than a day, reduces the overall glucose load. So at the first meal, you reduce the amount of carbohydrates. The body is experiencing less glucose in the blood. And then immediately what happens is you start to see this dramatic reduction in insulin, again, at the very first meal. Well, keep in mind when we talk about diabetes, we're talking about these elevations in glucose and these elevations in insulin. But when you reduce carbohydrates in the diet, you, at the very first meal, see reductions in glucose and reductions of insulin. When you see the reduction in insulin, you have this massive physiologic cascade. So insulin, I would contend, is the most powerful hormone in metabolism. It really is dictating not only multiple other hormones, but many of the enzymatic and physiologic processes of various tissues like fat, liver, and muscle. So when it reduces, insulin's reduced. When insulin's reduced, the amount of fatty acid oxidation, so the amount the body starts to break down fat, increases. So insulin stops the body from breaking down fat tissue to be utilized for energy. But when insulin is lower on the diet, again, at the first meal, you start to see subtle shifts in the body's ability to do a process called lipolysis. So lipo meaning fat and lysis meaning breakdown. So the breakdown of fat tissue that you have on the body. And that really starts this cascade of events where you start increasing the amount of fat being broken down from the fat tissue. You start to actually metabolize that fat for energy. You start to produce ketone bodies. And then ultimately your body starts to shift its primary fuel substrate away from glucose towards fat. And we know that in the context of things like type 2 diabetes, besides it being standard of care for virtually 200 years, we actually know that the American Diabetes Association in 2019 in their consensus report on nutrition regarded this as the most evidence-based dietary strategy for management of type 2 diabetes, at least nutritional management of type 2 diabetes. And so we've known that for a long time, but type 1 diabetes is a unique case where when we think about a disease state and we're trying to understand processes in the bodies and how things work, let's say if we're trying to tease apart the impact of glucose and insulin and their ultimate association with risk, in experimental scientific lab settings, we often use animal models or these cells in these petri dishes where we'll directly block a process of the body. So we'll directly change how glucose is absorbed. We'll delete a receptor or delete a hormone. Well, type 1 diabetes is an example of a deletion in the ability to produce insulin. So type 1 diabetes is a unique model of what we call insulin knockout model, and really allows us to tease apart the direct impacts of how insulin and glucose interact with the body. But in type 1 diabetes, we also know that the ketogenic diet, based on an abundance of emergent evidence, can be a very effective, potent, not only safe, but powerful strategy in potentially regulating glucose and also lowering the primary medication of this disease, which is insulin, which both are associated with risk of things like cardiovascular disease in these settings. So we know that the ketogenic diet not only has it been around for over 200 years as standard of care for managing diseases like diabetes and obesity, but it's a very physiologically sound approach due to the reduction in carbohydrates, leading to reduced glucose load, leading to reduced insulin, the two primary risks and biomarkers associated with the diseases of type 1, type 2 diabetes, and gestational diabetes. And we know that they have been shown to be effective at managing these primary risks that we know, we talked about earlier, ultimately lead to future disease. And that's the focus, and that's the interest, is finding strategies that have powerful effects at regulating those processes.
As Dr. Koutnik mentions, there are two main factors that drive metabolic disease: insulin and glucose. And a really easy way to fix this is to follow a ketogenic diet. Now, you can do this by simply dropping the carbs to under 50 grams a day. And some people need to even try zero carb or a carnivore diet. And that is the ultimate low insulin state. And I have seen so many people who have followed a zero carb or a carnivore diet and get incredible results. People have lost hundreds of pounds and even reversed metabolic conditions, things like heart failure and diabetes, conditions that your doctor would say it is something that you have to live with. And I myself have followed a high-fat carnivore diet for the past few years with incredible results. And what I found kept myself and my community on track was support through medical doctors. And that's why I created a private online community called Go Carnivore. It is a safe place completely off social media where you can ask all of your questions to our medical doctors, including the ones that you see on this health podcast. One of the best things about the community is our monthly challenges. We do challenges like a high-fat challenge, a dairy-free challenge, and this is what helps our members get the best carnivore results. So if you'd like to try carnivore with medical support, just head to gocarnivore.com and get 10% off your first month. For someone considering a ketogenic diet, maybe they have insulin resistance or diabetes, do you think they have to count calories to lose weight?
So there's been some evidence that even despite controlling calories, that some individuals who shift to lower carbohydrate intake can see reductions in body fat. That's actually from David Ludwig's group, where they showed this. However, the amount of weight loss independent of calories is very marginal. We see the most powerful effect of these diets when we talk about weight loss, when it leads to reduced intake of calories, in total calories, ultimately causing the body to start breaking down its own tissue to make up that caloric deficit. But it's also important to distinguish that from its ability to regulate risk. So independent of weight loss, we know that the ketogenic diet can improve glycemic control, not just in type 2 diabetes, but also in type 1 diabetes, which is, again, this very unique example where typically patients weren't historically overweight. They were normal body weight. They have elevated levels of glucose analogous or similar to type 2 diabetes, elevated insulin in the periphery, just like type 2 diabetes, same increase in cardiovascular disease risk, and even further reduction in life expectancy, just like type 2 diabetes. And when we look at this, we know that we can look at the biomarkers or changes. So a lot of people who go on a ketogenic diet with type 1 diabetes, their intent is not to lose weight. In fact, they often don't lose weight, but they see dramatic improvements in glycemic control. And the same is also true of many examples where calories are controlled in type 2 diabetes. But again, in the context of a disease like type 2 diabetes, where the change in glucose is really the end signal of this cascade of metabolic dysfunction, when we start to see improvements in glucose related to diet, it is an illustration of an improvement of multiple underlying metabolic factors. And we know that the ketogenic diet, through its reduction in carbohydrates, glucose load, and insulin, are able to improve outcomes, even independent of weight loss, in both of these conditions.
Let's talk about the long-term effects of a ketogenic diet. And you have just completed the longest study ever published on a high-fat keto diet. Can you discuss the methods and the results?
Yeah, this is a very passion-oriented project. The reason is because I myself have type 1 diabetes. I myself have lived with this disease for over 17 years. And I really embarked on my scientific career. Yes, I was interested in science. Like it's a really cool way to, like, you make money actually, like exploring cool ideas and concepts that interest you. Like it's a really cool path. But I really got into it selfishly because I myself had obesity as a kid. I also, in adolescence, so my long-term risk was dramatically higher for all the obesity-related complications. But I also got diagnosed in adolescence with type 1 diabetes. And throughout my life and career studying science, selfishly, I wanted to understand, how do we improve this condition? 99% of patients with type 1 diabetes will never achieve normal metabolic health, normal metabolic function. Only less than 1% of patients will ever get a normal glucose value, an average 2 to 3 month glucose value ever again after they're diagnosed. And when we think about these diets, they have these powerful therapeutic effects on regulating glucose and insulin. Again, two of the most powerful risk factors in the context of not just type 2 diabetes, but also type 1 diabetes. And type 1 diabetes, as I mentioned before, is this very unique condition where you don't have the elevation in fat tissue on average. You don't have increased adiposity like type 2 diabetes. You don't have elevated lipids, amino acid changes. You really just have elevated and variable glucose, just like type 2 diabetes, and elevated insulin. So you're looking at these two signals in isolation, and you can look at how interventions change that. But what was also really particularly interesting to me is that there was really no long-term evidence on the net benefit or risk of a ketogenic diet on cardiovascular disease, because one of the common effects of a ketogenic diet, particularly if someone's eating more animal-based fat, saturated fat, is the elevation in LDL cholesterol. And so what we were very interested in is looking at the longitudinal pre to post effect of type 1 diabetes when there was a switch from the Whole Foods American Diabetes Association diet, shifted to a ketogenic diet with data throughout a 10-year period pre to post, where the calories were controlled the entire time, exercise volume was controlled, body weight and composition was controlled, medication was controlled, and looked at the long-term effect, isolating out these key confounding variables of the net effect of the ketogenic diet, which can improve glycemic control and insulin. But people are concerned about the elevation in LDL. And in our particular study, it was over 10-year ketogenic diet with all these factors controlled, but there was a doubling of LDL cholesterol. So going from around 60 milligrams per deciliter to over 120 milligrams per deciliter, in association with elevations in things like ApoB, and known risk factors or known lipids associated with the atherosclerotic process in the general population. But what's so unique about diabetes is that there is this clear signal of risk related to glycemic control and insulin. So if you can do this diet that can potentially improve glycemic control and reduce insulin, what would the net effect be on overall cardiovascular function over a 10-year period? I mean, the longest trial that I was familiar with that looked at any type of serious cardiometabolic, so the interaction between cardiovascular health and metabolism effects, was really around 1, maybe 2 years, where they actually looked at the pre-value and the post-value. But this was a case where we were looking over 10 years in a patient population at 10-fold higher risk for cardiovascular disease, doing a diet that could dramatically improve glycemic control and insulin, but elevates LDL while controlling all these confounding variables. So this very unique study giving us potential incredible insights into this long-term effect, because there's really nothing over this period of time. In fact, the longest even case report of someone doing a ketogenic diet or something analogous to a ketogenic diet, so lowering carbohydrates, had been self-reported 10 years, but it didn't have pre and post data. It was just a post data report. And so we really didn't know what was happening. But in this example, we found that in type 1 diabetes, consuming a ketogenic diet over a 10-year period, the average glycemic control maintained over that 10 years was 5.5%. That's illustrating that in this population, the ability to maintain the top 1% glycemic control in normalizing glucose control over that period, something that most people believe is impossible, and doing so without additional medications, but simply the utilization of the shift in macronutrients in the diet, the reduction in carbohydrates. But it also led to a 40% reduction in insulin, which we know, again, is associated with insulin resistance, even in type 1 diabetes as well. Now, one of the other concerns that people were worried about beyond cardiovascular disease, which we'll talk about here in a minute, because there was a doubling in LDL cholesterol, was concern around kidney health, liver health, thyroid health, and bone mineral density. There have been, for example, in the context of bone mineral density, multiple studies that hypothesized that, within the first 1 or 2 weeks of changing to a ketogenic diet, that you see these adverse effects on molecules associated with bone mineral density health. But there was never any long-term data. Same thing with thyroid health. There was a speculation that reducing carbohydrates would lead to thyroid dysfunction, or the alteration in things like kidney or liver health. It's always been at the forefront of most clinicians' mind in association with the ketogenic diet. But what we saw over a 10-year period in a high-risk population, where we see early signs of cardiovascular disease dysfunction, alterations and reductions in bone mineral density, et cetera, there was no signal of any dysfunction in kidney, liver, thyroid, or bone mineral density, and no adverse events of actually administering this diet over a 10-year period. Again, something that is often cited as a concern for doing this, particularly in patients with type 1 diabetes. So again, this looked extremely promising. One, we were showing that over a 10-year period, controlling all these variables in this very high-risk population, that this diet had profound therapeutic potential, but also was safe. But when we looked a step further, the main concern that most people cited was cardiovascular disease risk. And so in association with a close colleague of mine, Joe Watso, we looked at the advanced cardiovascular physiology in type 1 diabetes related to a ketogenic diet. And this was so important because a lot of times people are looking at calcium score, which we can talk about and is a very important measure of cardiovascular disease risk. But well before someone's going to see an elevation in their amount of calcium in the body, which is basically a long-term measure of the amount of plaque in the body, we see early signals of cardiovascular and heart changes that ultimately lead to future risk. So in cardiovascular disease, there's a stepwise change in how the body is able to respond to pressure changes and stress within the cardiovascular system. And one of those early changes is we see within the first 3 to 4 years in children with type 1 diabetes, because of these high and variable glucose levels, that the vascular wall begins to stiffen. The amount of smooth muscle in the vascular wall starts to shift towards collagen. And so the vascular wall becomes very, very stiff. We also see that the endothelium, the inner layer of the vascular wall, becomes dysfunctional. It is no longer able to respond to what they call shear stress. So when the blood pressure becomes high, that pressure starts to rub against the vascular wall, shearing against it. So it's a form of stress. And normally when that happens, you're young, healthy, without disease, your body will vasodilate. Okay, higher pressure, we need the vascular wall to be bigger. But in those with advanced cardiovascular disease, or early on in diseases, even in childhood with type 1 diabetes, we start to see that the vascular wall can no longer vasodilate the same way. It is now stiffer. It's analogous for your audience if they turn on a hose and then they pinch the hose, okay? The water goes out much faster. Imagine if your vascular wall is much the same way, where you make the hose stiffer and you don't allow it to expand. The blood's going to move much quicker. It's going to cause much more stress against the inside of that hose, or in our case, inside the vascular wall. And these are the known early changes that eventually lead to inflammation processes, damage within the vascular wall, that ultimately LDL and plaque goes in to fix. And so the plaque that's being laid is actually there to almost heal a wound. So if you fall down and you scrape your elbow, your body puts this protective layer over it of a scab. Well, inside the vascular wall, the same thing is happening, where you have these high pressures, very stiff vascular wall. It's not able to vasodilate as well. And you have these damaging molecules at high levels like glucose that are starting to do the same thing. They're almost scabbing up the inside of your vascular wall. And so LDL goes in and lays, as a part of the process of laying plaque, goes in and helps facilitate healing that internal vascular wound. But in doing so, starts to progressively occlude or reduce the blood flow within the vascular wall, which ultimately, over time, leads to blocking the vascular wall and a heart attack. or a stroke if it happens in the brain. And so what we found in this high-risk population with tenfold higher risk for cardiovascular disease, with early signs of atherosclerotic progression, even in childhood within 3 to 4 years, we found that the ketogenic diet, despite doubling in LDL cholesterol, led to not only normalization of glycemic control, an over 40% reduction in insulin, but in association with that, no indications of stiffening of the vascular wall, no indications of any signs of internal endothelial dysfunction, no signs of what they call left ventricular dysfunction or adverse effects in how the heart functions. Even though we would expect all of these to occur within the first 3 years of the vascular changes, within the first 10 years of heart changes. And this patient had had type 1 diabetes for 17 years and on the ketogenic diet for 10. And not only were the cardiovascular physiology showing no indications of risk, but when you actually compare it to age and sex max individuals with type 1 diabetes, they had better cardiovascular physiology on average. But what's super fascinating here is that when we compared it to population level norms and individuals who had no disease whatsoever, we found that the cardiovascular function and physiology was often superior to individuals without any disease. In a population at high risk for cardiovascular disease and having that disease for almost 2 decades. This was a rather remarkable finding because at present there was mostly concerns and risk related to this topic and the disease. But what we talked about earlier here is that if we focus on the most important risk factors and correct those, it appears that that was the most important factor in regulating this process. Otherwise, if LDL was the primary risk and it led to early laying of plaque over things like glucose, we certainly would have expected to see adverse effects in the vascular wall, and we did not. We actually saw better cardiovascular function and health than individuals not only with type 1 diabetes, but also without type 1 diabetes. And this really laid the groundwork for an eye-opening insight into what is, one, the priorities in regulating risk, but doing so in a population who's at dramatically higher cardiovascular disease because of the elevation at much higher levels of glucose and insulin, which the average person also has to think about, because if they develop overweight, obesity, prediabetes, and type 2 diabetes, as we spoke about before, we start to see elevations in insulin. Then we start to see elevations in glucose, and it progresses as metabolic dysfunction progresses. So I believe this study provides incredible insights, at least preliminarily, into the long-term implications of this diet, and ultimately, what is the net benefit? And it appeared to be remarkably effective as a profound therapeutic strategy for regulating disease. We're not talking about a medication. We're not talking about a technology. In fact, in type 1 diabetes, there is no medication or a technological strategy, despite hundreds of years of advancement, that actually improves glycemic control to the same degree. In fact, over the last decade, patients with type 1 diabetes, despite dramatic increases in technological and pharmaceutical advancements and increased use of those tools, glycemic control has actually been shown to get worse. So what we're talking about here isn't a technology, it isn't a medication, it is a therapeutic strategy that is in the grocery store, it's in your pantry, and has amazing and remarkable effects on your body, but also and potentially regulating risk for chronic and even irreversible metabolic disease.
I do want to ask about the LDL cholesterol pertaining to saturated fat. When somebody increases this saturated fat, we do see an elevation in LDL cholesterol. Why does that happen?
Yeah, so there's a lot of associated data between the elevations in specific types of food within the diet. So if you actually look at fat intake, it isn't so much the fat itself that is causing elevations in LDL, although there is some data that suggests that. If you actually dissect apart the type of fat, it appears that things like saturated fat are in part contributing directly to the elevation in LDL, but not just LDL, but also things like ApoB, which people are often more concerned about because it's a more direct measure of the atherosclerotic component of LDL. So it's more about, it appears, the type of fat that's consumed in the diet than inherently fat itself. But it is diet related.
So, why does that actually happen? And is that a concern for somebody that is worried about heart disease and heart attacks? If they're eating more saturated fat from a high fat ketogenic diet, so more meat, more butter, more tallow, more lard, should they be worried when they see higher LDL and higher ApoB, but their HbA1c is coming down?
This is a very interesting and complex question because this gets back to what we were talking about before. Let's say in the context of my disease, and type 1 diabetes, is unique kind of circumstance where you have high and variable glucose levels and high insulin. Well, if you're able to do a ketogenic diet, you have to think about the hierarchy and risk. So the risk factors that ultimately lead to long-term negative outcomes. And so if you're able to do a diet or any pharmaceutical intervention, any technological intervention, or any combination therein, you have to immediately focus on what's the primary risk that I need to focus on. It's like driving a car. I need to focus on the engine and the chassis before, getting a better sound system or fancy rims, or the type of leather in the seats versus cloth seats. You don't focus on those things if the car doesn't function at all. So you think about priorities here and risk. And of course, in the context of diabetes, we know that glycemic control is the primary risk. We know that blood pressure is the second, again, modifiable risk. We can't change age. We can't change how long we've had the disease, but we can change things like glycemic control. We can change things like blood pressure. We can change, triglycerides, resting heart rate. And those are the things that are in a dose-dependent manner ranked 1 through 4 in modifiable risk factors in this disease. LDL is actually the lowest of those when associated with other risks. So it doesn't mean that LDL doesn't matter. In fact, LDL does have an association with risk in diabetes and in the general population. The risk is just infinitely lower comparatively. For example, there was a study, the big study called the DCC and EDIC trial on type 1 diabetes, the one that I referred to earlier, that had over 1,000 patients over 30 years in a randomized controlled trial setting, looking at the various risk factors. And that what they found is at the 30-year mark, what actually associated with the incidence of cardiovascular disease or events. And they found that LDL was significantly associated with cardiovascular disease, but the association had a hazard ratio of 1.07. So what does that mean to your audience? Well, 1.07 is relative to 1, meaning that the increased risk associated with every 10 milligrams per deciliter elevation in LDL was only 0.7% higher. So as you increased your LDL 10 milligrams per deciliter, you increase your cardiovascular disease risk 0.07%. But things like HbA1c, triglycerides, blood pressure had infinitely higher risk. So as you elevated or as you changed glycemic control, as you changed blood pressure, as you changed triglycerides or resting heart rate, those had much multifold higher impacts on the incidence of cardiovascular disease in this population. And one of the most refined studies ever done, because it was not only a randomized controlled trial, but it was in over 1,000 patients over a 30-year period. I mean, you almost never see a study like this. And you may never really, again, it cost hundreds of millions of dollars and probably won't ever be repeated, but it was done and it did show that those are the factors we have to worry about. So it doesn't mean you shouldn't worry about LDL. So let me give my personal example. I myself have type 1 diabetes. All the data says that I'm at increased risk for all 10 leading causes of death. I'm expected to have 10-fold higher risk for cardiovascular disease. I'm expected to get at least one term complication related to high and variable glucose levels, whether it be damage to the eyes, the kidney, vascular dysfunction, heart dysfunction, one of these various risk factors. I'm not might get them. I'm expected to get at least one of them. Every patient is expected to get at least one of them. And in that particular case, I'm thinking, what can I do to dramatically reduce my risk? I have a wife and 2 kids. I want to live a happy and healthy life. I want to feel good today, but also I want to feel good forever and live as long as possible. And I have to look at the data. I have to look at the evidence. What actually associates with risk? And when I look at the data on that is very clear that if I need to focus on my glycemic control first. Once I have that fixed, I need to focus on my blood pressure. Then I need to focus on my triglycerides. Then I need to focus on my resting heart rate. Things like exercise can improve that and those other metrics. Then after I got all that corrected, I can worry about the 0.07% elevation risk in LDL cholesterol for every 10 milligrams per deciliter increase. So these marginal increases, these marginal risks. Yeah, I would love to have all of them corrected, but the reality is that almost no therapeutic strategy doesn't have a risk to benefit ratio where it may improve some things and not improve all things. And so I want to improve the things that matter most. And if something is at risk and associating with improving the things that matter most, that's okay for me as a patient living this disease, because I want to have the largest net benefit for whatever I'm doing with my lifestyle over the long term. And so, yes, LDL does matter. Yes, it is associated with risk, not only in diabetes, both forms, but also the general population. But the risk, particularly in these high-risk cardiovascular disease settings, is so much higher for things outside of LDL. And that means that we should focus on those first and foremost, and then also focus on LDL once those are fixed, but never compromising the most important risk factors for something that is much less important. So it's always a net benefit, and ideally you fix them all. But sometimes interventions don't allow for that. So you have to consider the net benefit of anything you do in regulating your long-term health.
So if somebody is just thinking about this, maybe they don't have a chronic disease. So we spoke about diabetes type 1 and 2, elevated insulin, fatty liver disease. What if they're just kind of healthy? So a question for you, who should never or not do a ketogenic diet?
It's an interesting question that's not often asked because there's so many therapeutic effects of a ketogenic diet across many different settings that people often only focus on the excitement around the fact that, wow, you can change what you buy in the grocery store and what you consume from the grocery store. And it can have these massive impacts in these diseases where pharmaceuticals and technology that costs, hundreds of millions of dollars aren't able to do. But there are some contraindications, meaning examples of when someone shouldn't do this. And those are usually specific to what we call inborn errors of fat metabolism. So when fat metabolism, you aren't able to actually metabolize fat. That would be a clear indication that doing a diet very high in fat would be contraindicated or not recommended. We used to think that things like eating disorders were contraindicated, but that's in question now because there's emergent evidence that shows that people with eating disorders have actually been able to appear to correct in part some of their eating disorders by changing their diet. And that's a very interesting paradigm because often one of the high risks for someone developing an eating disorder is restrictive eating. And when someone, does a ketogenic diet, they're reducing the amount of carbohydrates. Some people assume that to be restrictive. I will also state that restrictive or reductions are all relative, right? So if you went to the grocery store and the only thing that was in there was fat and protein and there's a little bit of carbohydrates, most people would probably be consuming a higher fat and higher protein diet and less carbohydrates. It's really societally driven what we're predominantly eating. It isn't because we have to, it's because what's available and in higher portions. So what's normal is very relative to the individual and circumstance. But those used to be, so inborn errors of metabolism, those are contraindicated for sure. If you can't metabolize fat, that would be problematic. But also, what we used to think, like eating disorders, would be contraindicated, and in some circumstances, it may be ill-advised. There's actually emergent evidence, at least in smaller case report and pilot studies, that might actually benefit some people with those conditions. So those are the ones where we're more concerned about risk, but we also have to talk about where it may apply, right? Where are some of the net benefits of this diet? I mean, the therapeutic potential of this diet has been shown. Again, it was standard of care for type 1 and type 2 diabetes for 200 years. It's been shown by Rollo back in 1796, I believe, to correct obesity. And again, use as standard of care, correct obesity and type 2 diabetes for over 2 centuries. We know that it has been used for neurological disorders since the Mayo Clinic Wilder report back in 1921. And there's all this emergent evidence that this shift in metabolism associated with reduction in carbohydrates in the diet, which leads to reduction in glucose load, reduction in insulin, this physiologic cascade of events, including the elevations of ketone bodies, can ultimately have powerful therapeutic effects, not just on, let's say, obesity and type 2 diabetes and type 1 diabetes, but emergent evidence that it could have a powerful effect in fatty liver, what we now call MASLD, through the elevation in the enzymatic process of just ketogenesis, which seems to have an implicative effect in the disease process. We also know that things like neurological disorders, Alzheimer's, Parkinson's, that there's emergent evidence that either ketogenic diets or just the administration of metabolites associated with a diet, like exogenous ketones, potentially have therapeutic potential in attenuating some of the symptoms of these diseases. What's really, really fascinating is this emergence in evidence revolving mental health, or with this field of metabolic psychiatry, where these cluster of conditions, when we think about that, we're talking bipolar, schizophrenia, anxiety, depression, amongst others. We often thought, okay, right now there are virtually no really long-term studies that any medication is effective in these conditions. Yes, people use medications over the lifespan and have been for a long time, but we really don't have studies to show that, beyond 1 or 2 years, that these medications that are commonly used for standard of care for treating these conditions, like SSRIs and others, really have therapeutic efficacy or safety beyond these windows of time. And these conditions are rising at rapid rates in our society. We know that the rates of psychiatric or psychoactive substance use is dramatically higher, even in children. Rates of, unfortunately, suicide and otherwise the incidence of psychiatric diagnoses are much higher, dramatically higher, in fact, in the last couple of decades than previously seen. But there's this emergent evidence that the reduction in carbohydrates associated with the state of physiologic ketosis and the elevation of ketone bodies associated with that appears to have the potential for profound impacts in regulating this set of conditions in psychiatry that we would have, arguably never thought that something like nutrition would have an impact on. But what we're appreciating, and what we talked about in the very beginning, is that not just in obesity and diabetes conditions, but also in virtually all conditions, metabolism has a clear either causal or associated effect with health and in disease. And we know that changing mitochondrial functionality, the processes of metabolizing nutrients, to metabolite changes within the blood, to hormonal changes associated with that, these are all effects of metabolism. And almost all, I don't know of a condition that doesn't have changes in those conditions that either have direct causal impacts on regulating the disease process from occurring in the first place or potentially being reversed, but also in regulating symptoms related to the disease. And so underlying the hood of virtually all these issues is metabolism, and the dysfunction of metabolism being associated with many of these issues, but the correction of metabolism by altering or reversing a lot of the adverse metabolic effects often accumulated over time to lead to the disease or happen within the disease, can often be altered through nutritional change. And the ketogenic diet, or therapeutic carbohydrate reduction, as we now call it, is one of the most powerful ways to change physiology in association with diet. And it's quite remarkable and how much data we see in that. So there are conditions, inborn errors of metabolism, conditions we once thought, like eating disorders, that would be contraindicated. But there's this emergence of evidence really showing incredible promise across the board. And hopefully we'll learn more and more as we go about where and when it would apply and how to optimally apply these strategies in the context of each person. We're really, honestly, in early stages of understanding that end of things, which is how and when and how to optimize application of these strategies when they're applicable.
Absolutely. I do see people in the comments saying that when I did a high-fat diet, it didn't work because of XYZ reasons. For example, triglycerides, LDL, I gained weight. So understanding who it's for and who it's not for, and you gave some people that it might not be for, is important to understand. I want to move on to understanding physiological insulin resistance versus pathological insulin resistance. First, talking about physiological insulin resistance. If somebody's doing a long-term ketogenic diet, and their blood glucose is slightly elevated, a doctor's going to say, you have become insulin resistant because you're not feeding your body with sugars and carbohydrates. Is that a real thing and something that that person should be concerned about?
Yes and no. So when we think about insulin resistance, we're talking about and where we associate it with risk, we're talking about in the context of diabetes, and we see it often in early signs in obesity as body weight and adipose tissue accumulates. We're worried about that because of its known association with cardiovascular disease. The elevation in circulating levels of insulin can lead to downregulation of the insulin receptor, changes in insulin signaling, where the insulin molecule binds to the receptor and then ultimately causes a cascade of molecular changes within the cell to ultimately cause glucose uptake and normalization of glucose within circulation. We see that many of those molecules are altered in their signaling cascade, IRS1, hexokinase, and others. We also see the reduction in insulin clearance in the context of insulin resistance. In fact, one of the best examples of understanding the impact of insulin and its impact is actually in type 1 diabetes, where, again, we talked about patients who are often normal body weight, normal lipids, normal amino acids, and normal blood pressure, at least initially. Immediately upon diagnosis, when they start injecting exogenous insulin, they see insulin resistance. And what this is telling us is that even in children in normal body weight, just the administration of exogenous forms of insulin immediately cause insulin resistance. And this actually occurs also within 48 to 72 hours in individuals who don't even have diabetes if you just infuse high levels of insulin into the peripheral vasculature. So just the presence of higher levels of insulin has pathological consequences. But there's this interesting conversation, right, about this physiologic insulin resistance where, if you go on a low-carb diet, you're going to reduce the amount of glucose that you're metabolizing, and then you're going to increase fatty acid metabolism, and then you're going to become more, let's say, resistant to your ability to ultimately metabolize glucose. And a lot of that is largely focused on this process called the Randle cycle. A lot of people focus on this like molecular pathway called the Randle cycle, where I just simply put, in layman's terms, it's like how your body decides which fuel to utilize, sugar or fat, depending on what's available and what's needed. So if you have more fat you're fueling the body with, you would burn more fat. If you give more glucose, you burn more glucose. And as you increase the amount of fat and lower glucose, you would preferentially shift towards fatty acid metabolism. And it's kind of like, two fuel sources, like electricity, glucose, and gasoline for fat, and whatever one you choose to use, you preference in that way. But I also one problem with the Randle cycle is very reductionist, right? It assumes that this is a one or the other type of circumstance. And I will tell you that oversimplification, that reductionist mindset in science almost never applies. In fact, we know it doesn't apply because we have studied numerous individuals over, multi-week and often sometimes multi-month ketogenic diets where we've actually assessed whole body substrate oxidation. So the amount of carbs being metabolized, the amount of fat being metabolized, not only at rest, but actually during stress, like exercise. And what we find is that individuals who completely adapt to a ketogenic diet over 4 to 6 weeks, we see ketones elevate, we see insulin lower, we see glucose reflective of the diet change. And they have multiple other adaptation changes that occur, like ketone elevation, that eventually normalizes. Once they normalize in this state, we still see they're oxidizing glucose, even though they're oxidizing infinitely more fat. So it's not that people can't oxidize glucose. They're just using more fat and less glucose proportionately. And yes, if you fuel with more glucose or more fat, you may preference it. And that is true. In fact, that's also why oral glucose tolerance tests are not valid on a ketogenic diet, because and that's been known for almost 100 years. It as a part of the methodology of the test, it specifically has stated for 100 years, if you do this assessment, you should not do so if you're in a carbohydrate restricted state because of the known shift in fuel preference. But the oversimplification using kind of pathways like the Randle cycle, which is a real pathway, it is applicable, often leads people to think that, oh no, I'm going to get insulin resistance associated with a change in diet because I'm going to shift more towards fat and then I can't really tolerate carbohydrates anymore. And while in part that may be true for some individuals, we know in our studies, over multiple studies, not one study, but multiple studies, that you never stop utilizing essentially all fuels. You just preference some more than others. And you always will use some versus others depending on the context, whether it be diet-induced, whether it be exercise-induced and beyond. So is physiologic insulin resistance real? There's partial shifts in the amount the body responds to glucose with dietary change. If you lower glucose and increase fat, you'll be able to burn more fat, preferential over glucose. But is that pathological? Absolutely not. We know that the pathological component of insulin and related to insulin resistance is tied to the peripheral elevation over time that is markedly higher. I mean, 2 to 4-fold, up to 6-fold higher in these conditions. This is not the same thing as physiologic insulin resistance, and arguably physiologic insulin resistance is more of a kind of interesting term and topic that I don't really feel is as applicable as people think it is in these circumstances. It certainly isn't pathological in any particular way. So I often don't put much into that, but it is an interesting physiologic effect for some individuals on the spectrum, if that makes sense.
It makes sense. I just thought I'll ask that because a lot of doctors will say you need to eat carbohydrates so that your body knows how to burn glucose. But as you mentioned, due to the Randle cycle, or your body just knows how to. The idea about a healthy metabolic state is that the body can shift towards burning ketones or burning glucose as an independent variable for fuel. But it does both, even if you're on a high-fat ketogenic diet, consuming low carbohydrates. And so the pathological form of insulin resistance is when you have a disease, insulin resistance, or if you have diabetes or anything causing that. Physiological is when you deprive your body of carbohydrates, and then it's saying you're going to get insulin resistance because of that. It's not actually real. I want to talk about how somebody can create a very well-rounded ketogenic diet. How much fat did people eat in that long-term study?
So around 70%, which is actually very common. You know, historically speaking, when we thought about the therapeutic effect of a ketogenic diet, it was often citing historical studies in epilepsy because people thought that was some of the original work on a ketogenic diet, when in reality, obesity and type 1 and type 2 diabetes was the original work, historically speaking, in the ketogenic diet. But that was a extremely high level of fat, over 90% of total calories by fat, which when someone says I'm doing a ketogenic diet, virtually no one is doing that. They may think, and they call it a 4-to-1 ketogenic diet or 90% by fat ketogenic diet. Almost no one is actually doing that. It's very actually hard to achieve. It's a lot of fats, a lot of oils, and very little protein, and virtually an absence in carbohydrates. So you don't see that. But in the studies that we have conducted, we often see more like a 2-to-1 ketogenic diet, which is around 70% of the total calories by fat, around 25% from protein, around 5 to slightly less than 10% of calories from carbohydrates, which is the actual definition of what we term a very low carbohydrate diet. Your audience should probably become familiar, if they're not, that there is distinction between just low carbohydrate and very low carbohydrate. And an even further distinction between that and the ketogenic diet, where low carbohydrate is actually around 50 to 51% to up to 100 so 51 grams of glucose up to 130 grams of glucose, or around 10 to 25% of all the calories from the diet coming from carbohydrates. But very low carbohydrate is what most people think of when they think of the therapeutic diets that they've heard of, like a ketogenic diet, because those are typically less than 10% of total calories coming from carbohydrates in the diet, and typically less than 50 grams of total carbohydrate intake. But again, it's dependent on the situation. So if you're a child doing this for epilepsy, you probably aren't consuming 50 grams. You're probably consuming, maybe closer to 10 to 30 grams of net carbohydrates or less. So it really depends on the circumstance, but we usually go based on percentages because percentages account for age and body size differences. But that's the typical breakdown when we think about these different diets. But keep in mind, when we talk about a ketogenic diet, it's also often ascribed to this 70 to 75% of total fat, 20 to 25% from protein, around 5, maybe up to slightly less than 10% of total calories from carbohydrates. But it's actually in the term ketogenic, meaning the production of ketones, that is the metabolic biomarker of whether someone is in ketosis or not. And so I often like to think of these in categories which we have published on and defined as high carbohydrates, which is greater than 45% of total calories by carbohydrates, moderate carbohydrate, which is around 26 to 45% of calories by carbohydrate, which is actually what most people are eating nowadays. This is similar to a Western diet where you kind of have high carbs and high fat. Then you have low carbohydrate, which is 10 to 25% of total calories by carbohydrates. And then less than 10% of total calories by carbohydrate is the very low carbohydrate diet, which most people think of when they think about therapeutic effects of low carbohydrate intake. When you have the elevation in the ketone bodies on top of that, that's when we start thinking about therapeutic ketosis, or what we call a ketogenic diet. So there's clear distinctions between the various types of diets based on the amount of carbohydrates, but also the amount of, let's say, metabolic increase of things like ketone bodies as well.
So if someone is thinking about those macros, might sound a bit confusing. What do you think are the top 5 foods that somebody needs to eat to do a well-rounded ketogenic diet?
Ooh, good question. And that's actually really hard for me to answer because I usually don't think of it that way. I usually think about, because it's so, context dependent. It's so person by person individualized. Maybe they have cultural factors, individual factors, or they respond better to some foods versus others, or maybe they don't have access to certain foods. But typically when people think about a ketogenic diet, and let's say let me rephrase it and constrain myself a little more and say, what would I consume if I was only given 5 foods to eat for the rest of my life for a ketogenic diet? I would primarily think about something like, honestly, not a very fancy answer, but eggs. Eggs is a very macronutrient, micronutrient dense fuel source that has both protein and fat at good ratios. You could consider beef or something like salmon. One would, people like the idea of fish better because of the association with health benefits of fish. So you can say things like salmon. I don't exclude the vegetables. Some people do if they're doing something like carnivore diet, and power to them if it's producing benefits for them. But I do like to have fiber in the form of, let's say, broccoli or spinach. I would actually contend that if I could choose one of those, I'd probably go with broccoli. It has a higher fiber to total carbohydrate net ratio, and it has it's very micronutrient dense. Some people probably are mad I didn't say kale because it's supposed to be a superfood, but whatever, I chose broccoli. Beyond that, I would probably go with some form of nut. I am a big fan of macadamia nuts. In fact, I don't actually have them that much because I was definitely I was formerly obese, and so if someone throws a bag of nuts in front of my face, I'm not going to sit here and pretend like I don't have subconscious levels of desire to eat not only the whole bag, but maybe 3 of those bags. But I probably would do macadamia nuts if I could choose. They have a high fat content, and they're also plant-based. So I like the idea of diversity. I'm not all or nothing. I'm not all animal-based fats, not all plant-based fats. I think a balance is a good strategy. And so I'd probably choose macadamia nuts. And then I'd probably choose some type of intermediary between those, something like olives or because you can make oil out of it, which is also it's a plant. It also has oils and fats, and it comes from a healthy source, but it also comes from a plant source. So I'm diversifying between animals, fish, fiber sources that are low in the net carbohydrate impact, and also things like nuts and or olives. If I had to be constrained and choose, of course, I want all the options and extreme flexibility. But if I didn't have those options, that's what I go for.
That is such a detailed response. Okay, last question for you. If somebody's just on the fence about a ketogenic diet, thinking, I don't know if I can do it because my family is not doing it, it's too hard, it might be expensive, all the fat and all this kind of stuff, what is your best advice for them?
The biggest constraint that we often hear about is, and I think about this a lot in the context of type 1 diabetes, because the type 1 diabetes is peak age of diagnosis is 10 to 14 years of age. So it happens in childhood, is I want to be able to eat like my friends eat. I want to be able to go to my friend's party and have the food they're having. I don't want to give up my favorite foods forever. And I guess the way to think about this is, what are the foods that you think you should be eating? When you visualize health, most people are visualizing a salad. Most people are visualizing, like blueberries or blackberries, salmon, foods like this. And then, having all of them within reasonable amounts and in moderation. You might think of squash too. You might think of, but we don't think necessarily of like rice as a health food or bread as a health food. You often think about what's healthy. A lot of the things in a well-formulated ketogenic diet pop up in your mind. And so it's something that you can formulate and be health focused. But when you think, okay, well, I don't want to give up my pizza. I don't want to give up my donuts and da. Well, keep in mind that if you ideally probably shouldn't have any of those foods, at least not a lot of it and not often. But if you really did want to have it, you can make low carb versions of this. And arguably, that's a better alternative. And why do I say that? Well, a lot of times, if you were to go to the store and buy a cake for someone's birthday, it is absolutely loaded to the brim with rapidly digesting sugar and carbohydrates and fat simultaneously, both at the same time. This is when you have the worst metabolic effect, is when you have high fat and high glucose simultaneously together. But what you could do is you could have made that cake that is, let's say, with almond flour or coconut flour instead of whole wheat flour. And now you can actually exchange things like sugar for things like stevia, monk fruit, allulose, one of these other safe and healthy alternatives that don't have calories in them or virtually no calories in them. And so actually doing this diet, I think, is a really powerful way to learn how to actually replace what is arguably very unhealthy forms of food that are abundant in Western society, and it actually make them healthier. Because no, you don't, I'm not telling anyone you have to do the ketogenic diet. You don't have to. You don't do it if you don't want to. Don't do it if it doesn't benefit you. If you don't feel great, as long as you've done it the right way and you've had good guidance and how to do this, because there's a ton of bad advice out there on how to do this. But if you're doing it the right way, you've had good, clear guidance, do whatever you want. But that said, you should do it appropriately, and you should arguably focus on how to make this diet sustainable. And so I have done this diet for over a decade, and I live with a disease where it helps manage my primary risk factors. And so I want to make it sustainable. So if I have my birthday, my wife's amazing and she's incredibly supportive because she sees how profound of an impact it has on my disease control. She's not waking up every night checking my blood sugar, worried about whether I'm going to go low all the time. Like it's dramatically improved our family's life, my life on a regular basis. And so if we want to make something fun for a birthday, she'll pull up, a website. Actually, you can use ChatGPT nowadays. It's really, really effective. But there's a website called All I Dream About Is Food by Caroline Ketchum, which has an amazing list of very, very delectable foods. Wouldn't say they're low on the calorie end though, but they sure do taste good. So if you ever wanted to make something that's fun, or you're going to a birthday party, you want to make pizza, you want to make donuts or cake, you can make all of those foods and make them low carb. But in doing so, you are actually learning not only yourself, but your whole family, if you do it together, how to often swap out ingredients of foods, make it on your own, and arguably make it way healthier, because you're often replacing things that we know ubiquitously are not ideal in the diet, like high sugar, with things that are safer alternatives that allow you to have that sweetness if you so choose. But you don't have that huge caloric load. You don't have that huge glycemic spike, that huge insulin response, and the associated metabolic consequences of that, not only at that meal, but if you consume it over time. So I think it's important for people to understand those things, because nowadays, if you don't understand them, you're really vulnerable to what is a extremely dysfunctional food environment, particularly in the Western world, where you go to the grocery store, you can find a food that says, oh, healthy, whole food, a ketogenic diet. And reality is that that's not actually true at all. I've consumed foods that have the same calories, the same macronutrient distribution, both say keto friendly on the front, and one spiked my insulin over 300%, increased my blood sugar over 100 milligrams per deciliter, whereas the other one had no effect on glucose, no effect on insulin. And so if you're focusing on a diet like this and you make it whole foods, you'll learn how to eat the right way with the right ingredients, you're often learning how to eat better in general. And you can apply that strategy whether you stay with the diet or not, that not just for the person who may do this primarily. Let's say you have a son with type 1 diabetes or a daughter with epilepsy and you're doing it for them, but you yourself will learn along the way. And I would be surprised if it won't have an effect on them as well, because in today's society, over 40% of kids have some type of chronic condition. Over 70% of all adults are obese or overweight. Over 50% of the adult population is pre-diabetic. Some would contend that the levels of insulin resistance are even higher than that. There have been studies that have looked at the incidence of optimal metabolic health. Let's say you don't have elevated glucose or waistline or body composition, normal glucose levels. They show that less than 10% of the American population actually fits optimal metabolic health. So at this point, when we think about optimal dietary strategies, almost the entirety of Western society is dealing with this. And so as a result, understanding diet, understanding powerful therapeutic dietary strategies that can correct metabolic dysfunction, like therapeutic carbohydrate reduction and ketogenic diets, is an extremely important learning tool, I would contend, to understanding how to live a well life. But I won't negate, things like exercise, sleep, and other factors are also really important.
Absolutely. Couldn't have said it better. Andrew, if people want to find you more, where can they find you?
AndrewKoutnik.com. It's a website. I've provided a ton of free resources where people can go and learn as much as possible. I also have a Substack letter where I post articles on, I think, key topics. You can find me on Instagram, X or Twitter, whatever you want to call it, TikTok, and beyond. So if anyone's interested in following me on one of those various platforms, they can find it all at my website. It's AndrewKoutnik.com.
Perfect. All the links are going to be in the description. Thank you so much for your time.
Thank you so much for being here.